So we just had the drawing for the Visa gift card, and the winner is Kevin Gaffney. Congratulations. Congratulations. Okay, so we're about to start the last segment of the morning session, and our next speaker is Dr. Friedman. Her topic is on Pseudotumor cerebri. Dr. Friedman is a professor of neurology and neuro-ophthalmology at UT Southwestern. She has published extensively on this topic, and she's about to talk on a topic that I find very challenging, interesting, and can't wait to hear what she has to say. Dr. Friedman.
Thank you very much, and thank you so much for inviting me to speak. It's great to be here. I trained at Baylor in Houston just a few years ago. Happy to say that just a few, not many, only my hairdresser knows for sure, and was in exile in central New York for 22 long, cold years. So it's great to be back in Texas, and it's nice to be here, and actually half of my residency class from Baylor is at the meeting, so it's really good to see everybody. I have a few disclosures. Basically, everything that I talk about is off-label. Nothing is on-label for pseudotumor cerebri, or IIH. We actually now have evidence. So I used to get up and give this talk and say, well, you know, I'm just making all this stuff up, and nobody can tell me that I'm wrong because we have no evidence. Well, we had a clinical trial, so now we have some evidence. I was on the steering committee, and I was the medical monitor of that clinical trial, and my commercial disclosures are pretty much more or less irrelevant to this. So there have been many renditions of the diagnostic criteria for pseudotumor cerebri syndrome. And I like to use that term because it kind of encompasses everything. It encompasses the idiopathic form as well as the secondary causes. And the most recent revision was done in 2013, largely to, again, reflect new things that we've learned in imaging, and also to kind of address the IIH without papilledema issue, as well as include diagnostic criteria for children, which had never been really written before. So to make a definite diagnosis, and I really encourage you to use the criteria. It will keep you out of trouble. The patient has to have papilledema. They should have a normal neurologic exam, except perhaps 6 nerve palsy or other cranial nerve abnormalities less commonly. Their neuroimaging should be essentially normal. We'll talk about the subtle things that you see in the neuroimaging studies, but no obvious secondary cause for intracranial hypertension. If the patient can't have an MRI, which is the recommended test, then we would recommend a CT scan with contrast. And we'll talk about all this stuff in a little more detail. Their spinal fluid should be normal, and they should have an elevated opening pressure, which for adults is 250 millimeters of spinal fluid. In children, which we have actually much better studies that tell you what's normal in children, 280, unless they are not sedated and not overweight, in which case it's 250. Why it should be different in kids, I don't know, and I'm not sure that it really is. So if the patient meets all of the criteria, except you go to do the spinal tap and the pressure is normal, but they have florid papilledema and otherwise everything fits, you can say that they have probable pseudotumor cerebri syndrome. You may want to repeat the spinal tap. So the evidence that I'm going to show you comes from the Idiopathic Intracranial Hypertension Treatment Trial, which was funded by the National Eye Institute, and we studied patients who had mild visual loss. The primary outcome of the study was to compare 2 different treatments. And so the first was acetazolamide, and the other was matching placebo, and then everybody had a dietary intervention. And the primary outcome was visual. It was looking at changes on the visual field, which I'll explain to you in just a minute. We also tried to see if we could get a better understanding of the cause of idiopathic intracranial hypertension. So we did some vitamin A studies, and we looked at various retinol factors, and we also collected serum from patients and age match and weight match controls and gender match controls also to look for genetic abnormalities that might be associated with the disease. So this is just the basic flow of the study. We took patients who were eligible based on their diagnostic criteria as well as their visual field parameters. They were randomized at 38 study sites in the US and in Canada to either get acetazolamide or placebo. Acetazolamide was started at 1 gram a day in divided doses and gradually increased at a schedule up to a maximum of 4 grams a day. And then there were matching placebo tablets that were increased in dose in exactly the same way. Everybody had access to a weight loss coach at the New York Obesity Research Center, which is located in New York City, and they have a lot of experience with clinical trials. And so the patients were contacted by telephone, and they worked with a weight loss coach. They were put on a low-sodium diet, and they were put on a weight loss program that was really tailored to them and their needs. So there was no specific diet that was used. And then the primary outcome was measured at 6 months, and the ancillary studies we already kind of talked about, and those patients were followed for a couple of years so far afterwards. So what is parametric mean deviation? What was the primary outcome? For those of you that are not familiar with looking at automated visual fields, these are from it's called the Humphrey brand of Perimetry, and it measures the central 24 degrees of the visual field. So the data are actually over here. These are what the patient produces. If anybody has never taken a visual field test, it's done one eye at a time. The patient sits in the machine. They look straight ahead at a fixation target. A bunch of lights are flashed at different points throughout the central 24 degrees in a standardized array. And they're the same size target, but different degrees of brightness. And so the patient just looks straight ahead. Whenever they see the light flash, they press a button, and the machine, the computer software in the machine tries to detect what is called the threshold value of brightness. So at every point in those 24 degrees that is tested, they're looking for the minimal intensity of brightness that the patient can detect, and that's called the threshold value. The threshold value is measured in decibels, and it's actually printed out over here. And then the software just kind of generates the rest of the printout. So the first thing it does is it kind of makes an artist's rendition of the visual field. So it fills in the spaces between those points that are separated 6 degrees apart. So the patient's looking straight ahead. And if you pretend this is your right eye, this is what your visual field could potentially look like. So the lighter it is, the better they see. The darker it is, the worse they see. That's the physiologic blind spot, which is enlarged. It takes those data and it compares it to aged matched normal controls. And it, for every value over here, it compares that value to the age matched normal control value. It prints out the difference over here, which is usually a negative number because our patients are not as good as age matched normal controls. And if you take all of those numbers and you average them, that is the parametric mean deviation. So it's a summary value of what the patient reports compared to an age-matched normal control. So in order to be in the study, the patient had to have a mean deviation of between -2 and -7 decibels. Between 0 and -2 is considered normal. So this patient has a -4.41 decibel mean deviation, so all of the things being kosher, they would have qualified for the study. I'm not going to go through this whole thing, just to kind of point out that the groups were very similar because of randomization. The major difference, if you look at who finished, who didn't finish, and why they didn't finish, is the treatment failures. So in the patients who were randomized to acetazolamide, we only had one treatment failure. That is, the patient continued to progressively lose vision despite being treated, and they had to be taken out of the study and treated in a different manner. Compared to 6 patients who were randomized to placebo. So we know that this disease affects primarily overweight women, at least in adults and teenagers of childbearing age. The incidence data are relatively old. So the probably best and most widely quoted incidence data come from Louisiana and Iowa, neither state really being known for being slim and trim. In 1988, when the studies were done, the overall incidence was about 1 in 100,000 people. But if you kind of narrowed it down and looked at the demographic that we're interested in, women who were between ages 20 and 44 who were overweight, then the incidence went up to about 20 per 100,000. We rarely see this in people over age 45. There was another set of studies that was done about 10 to 12 years later. One was done in Mississippi, one was done in Philadelphia. And in Mississippi at the time, they had the distinction of being the fattest state in the union. They, I think, have been, that honor has been taken over, I believe, by Alabama, but I could be wrong. But it's somewhere, it's a surrounding state. So the average BMI in Mississippi at the time was 25. But a quarter of patients living in Mississippi were considered obese. They had a BMI of over 29. And they found that the incidence had basically doubled in that 10 years. And similarly in Philadelphia, too many cheesesteaks. You know, their claim to fame was being the fattest city in the United States. And they, again, found an annual incidence much higher than what was found in 1988. And you can only imagine that it's probably a lot higher now, right? So from the data that we got from the IIH treatment trial, my other interest is headache medicine. So we looked pretty carefully at what their headaches were like. And to make a kind of a long story short, they were bad. So 84% of patients had headache at baseline. It was the initial symptom in about a third of patients. We measured headache disability using the headache impact test, the HIT-6, and found that at entry, the average person who had headache had severe disability from their headache. The cutoff between severe and very severe is actually 60. So it's pretty close to very severe disability. A quarter of patients had daily constant pain, and the median was 12 headache days a month at entry. 42% of patients were being awakened from sleep because of their headaches, and 51 of about 129 patients who had headaches were overusing symptomatic medications at the time of study entry. I think it's interesting that 41% had migraine. Of the 165 patients in the study, there were only 4 men. So this is primarily a women's clinical trial. And you would expect with women that 18% would have migraine, but 41% had a history of migraine. So I don't know if there's something about that, but I thought it was interesting. In summary, when we looked at all of their characteristics of their headache, we found that not only was it common and severe, but it was usually the presenting symptom, even in these patients who had relatively mild vision loss. There was nothing specific about the headache. It could sound like migraine, it could sound like tension-type headache, it could sound like none of the above. But the most common phenotypes, when we looked at the specific attributes of the headache and tried to match it to the International Classification of Headache Disorders criteria, were either episodic migraine, chronic migraine, or episodic tension-type headache. And of those people who had chronic or daily headaches that sounded like migraine, about 90% of them were overusing symptomatic medication. There was no difference in spinal fluid pressure in aggregate between patients who had headache and didn't have headache at baseline. At 6 months, and this has actually not been shown before, and we're in review in a journal at the moment, there was no correlation between headache disability at 6 months and anything you can think of. No correlation with opening pressure. Okay, so a lot of people tend to follow the opening pressure, and you know, the patient continues to have headaches, and you know, what's going on with the pressure? It has nothing to do with their pressure. No correlation between papilledema grade, the mean deviation, whether they were overweight, what treatment they were assigned to, how high of a dose they got on their study medication, whether they were taking hormonal contraceptives or not. We allowed that. It was not a problem in the study. Whether they had any of the things that we consider comorbid with headache disorders, anxiety, depression, or whether they had polycystic ovarian syndrome. So these patients at 6 months, many of them persisted in having headaches, and the headaches seemed to be independent of all of the other factors we could think of to look at. By 6 months, only 4 of the patients were still overusing analgesics. Part of that was that we educated our study investigators to get the patients off of those analgesics they were overusing, and part of it was because headaches in general got better. The other common symptoms, transient obscurations of vision. I like to hear about this when I'm interviewing the patient. It's present in more than half of patients where they transiently lose vision and then it comes back, or maybe the vision just grays out a little bit and then it comes back. It's often precipitated by bending over and then standing up again, and it lasts a few seconds. It can be in one eye or in both eyes, this actually turned out to be a very disabling symptom for patients. It's a reflection of papilledema, and it was surprising to me how disabling it was, but I guess when you think about it, it makes sense. Patients are driving, down the freeway and their vision goes out, that's disabling. So the other symptom, intracranial noises or pulsatile tinnitus, present in about half of people. Many people will tell you about this, right off the bat when you're interviewing them. Other people you have to ask, are you hearing noises in your head? And then people kind of say, what? No, not voices, noises. It's different, right? So people don't want to tell you when they hear stuff in their head, right? They think you're going to send them down the hall to that other department. So I have to ask about it, but it is very common. It is not specific to pseudotumor, but it is one of the more common conditions that it occurs in. Visual loss, we don't like to hear about that because that means that kind of things have already gone too far. But many people will present with visual loss as an early symptom. They may just describe blurred vision. Often people notice their visual field defect. And the first visual field defect that people get is enlargement of the blind spot. So sometimes they'll come in and they'll say, it's like there's something over there, like I'm seeing something dark over there on the side of my vision, but when I look, there's nothing there. And they're describing the enlargement of their blind spot. People can get other visual field defects. We'll talk about them shortly. But tunnel vision can occur. This is one of the few organic reasons that people can have tunnel vision, besides functional visual loss, very similarly to glaucoma. And of course, a small percentage of patients will progress to have very severe visual loss or even complete blindness. Other symptoms you might hear about, double vision. Usually it is binocular and it's horizontal. So the images are separated horizontally because of the 6 nerve palsy. Rarely you'll hear about a vertical double vision. Neck pain was present in 42% of our patients in the study, a little higher than I would have guessed. So ask about neck pain, ask about back pain. Occasionally people get radicular pain, either down the arm or down the leg. Joint pain has also been reported, as well as ataxia and dizziness, probably a little more common in kids than in adults. With more long-standing disease, these patients do tend to get quite a bit of depression. Many people will complain of disturbed hearing that we don't always ask about, but kind of this high altitude, I feel like I need to pop my ears sort of sensation. And some people will say when they have their diagnostic spinal tap that they feel their ears pop and they can hear again. We did a study when I lived in Syracuse a long time ago. I did a study with an endocrinologist who was interested in sodium and water retention. It's called Idiopathic Edema, and we found that of the 30 patients that we studied, about 90% of them actually had systemic fluid retention. So this may not be just a brain disease, we're not sure. So what we're really looking for is papilledema, and there's a grading scale that's used for papilledema. It never looks this good to us, right? In the neurology clinic, it never really looks like this. The ophthalmology, they get the better views. I didn't put grade 1 in there because it's so subtle that half the time it's hard to really tell. But grade 2 disc edema, you're going to start to see that the margins are indistinct. The optic nerve becomes raised, and you get this incomplete peripapillary halo. Grade 3 disc edema, the peripapillary halo is now circumferential. It goes all the way around. And you'll start to see, in addition to the grade 2 findings, that when the major blood vessels in the retina start crossing the disc margin, they get obscured by the swollen nerve fiber layer. So as you try to follow them in, most of them over here I can see, but maybe over here there's one that's coming in that you can't quite see it very well as it's crossing the disc margin. When you get to grade 4 papilledema, not only do you miss them crossing the disc margin, but you'll also miss parts of the vessels over the disc itself. And you still, well, with many people, you'll still see that peripapillary halo. And then grade 5 disc edema, multiple vessels missing as you look over the disc itself. So that's very severe papilledema. And when you look at the pictures, that one sort of looks worse than that one, But that's because the patient has some exudates out here and they may have some hemorrhages. Those don't really help you that much, okay? So the things that look really, dramatic, like in this patient who has a lot of hemorrhage and she's got a lot of exudate, what's really important is looking at those blood vessels as they cross the disc margin and looking at the blood vessels as on top of the disc margin. So this actually is high-grade papilledema, but she's also got a lot of exciting stuff to go along with it. Remember that once the patient has already had disc edema and it resolves, or once the patient develops optic atrophy, that nerve may not swell anymore. Dead axons don't swell. So this is a patient who had pseudotumor and also had Turner's syndrome, actually. And this is what she was left with afterwards, so her disc is pale. And as you look at the margin of the disc, it's not very crisp and clear. And this is called secondary optic atrophy or dirty optic atrophy. And it's the kind of atrophy that happens after the disc is swollen and then the swelling goes down. And it's just caused by this gliotic appearance and gliotic changes of the nerve fiber layer that you're looking through. What causes it? We don't know. So I only have one slide on pathophysiology, and the short answer is we do not know what causes this problem. So the two major, possibilities are there's a problem on the production side. Maybe these people are producing too much spinal fluid. They can't absorb it fast enough because they're producing too much. But most people think that the problem is on the absorption side, and probably having to do with venous hypertension in the brain. There may be a component of lymphatic drainage of spinal fluid. So now we know that there are lymphatics in the brain. We've known for a while that there are lymphatics around the olfactory area. And it could be that there's a contribution of lymphatic drainage to pseudotumor, but there's not so far a lot of evidence that that is the case. But certainly we know that there's a correlation with venous absorption, and that was actually postulated by Dandy in the 1930s when he first was one of the early describers of the disease. So in addition to papilledema, we're going to be looking at visual function. Most people with papilledema have pretty good visual acuity early on. If you see somebody who comes in with pseudotumor who has already lost central vision, that's a bad sign. Remember, it affects the peripheral visual field, right, before it affects the central visual field. So unless the patient has macular edema that could affect central vision, then their disc edema and their poor central vision is going to reflect loss of axonal function of the optic nerve. So remember, this should be best corrected visual acuity. Have the patient put their glasses on when you test their vision. Visually evoked potentials are not helpful. Perimetry is what we really, hang our hat on for pseudotumor. It's probably the most helpful test that we do, and it's the most helpful test for following the patient. This should be real perimetry. So, the visual field dance, do you guys do the visual field dance? How many fingers? Where are they? The visual field dance is not incredibly helpful, but if you do confrontation visual field testing in all seriousness, and you find that there's a problem, then there's really a problem, okay? So if you find normal confrontation visual fields, that does not exclude that the patient has visual field loss. But if you find that there's a problem, you better believe that it's real and that patient needs your help. So the most common visual field defects we're going to look for: enlarged blind spots, present in almost everybody because they have swollen optic nerves. And then the next common pattern is an arcuate field defect, which comes from a problem with the way the retinal nerve fibers enter the optic nerve. So you're going to start to see this pattern of arcuate visual loss. It's often pretty common inferonasally. And sometimes patients will get generalized constriction. Well, this lady came in to see me when I lived in Syracuse. She drove in from Albany, which is about 2.5 hours away. And that's considered a long drive in New York. In Texas, that's just like commuting to work, right? So she drove in from Albany, and she actually played golf. And she had a previous diagnosis of pseudotumor, and she really did have pseudotumor several years before. And they sent her to see me because they couldn't understand like why she just still had such bad-looking visual fields. She had good acuity, as you expect, because her central vision is good, but she's got these really bad-looking visual fields. But when you look at the center of them, you can see that it sort of looks square, right? Our visual fields, they're not square, right? They're oval. So as it turns out, this patient had functional or non-organic visual field loss. When we put her in the Goldman, the kinetic perimeter, and retested her again, we were able to show that her visual field did not expand as the target got bigger. So this was not real visual field loss. And this is not that uncommon. And it can really, lead you down the garden path to do unnecessary procedures on patients if you don't realize that patients can occasionally get functional visual loss on top of having real disease. Ocular motility, usually normal. Sometimes patients may get a 6th nerve palsy. Other patterns are pretty uncommon. Very rarely we'll see patients who have more generalized ophthalmoparesis. Think about a secondary cause, particularly venous thrombosis in these patients. Let's move on to diagnostic tests. So the first one we're going to do is image the patient, preferably an MRI. And one question, do you need to get an orbital MRI? Most of the time, we can see the changes we're looking for on a brain MRI. They show up better on an orbital MRI, but I'll show you what they look like on both. So what are we looking for? Well, normal brain parenchyma, right? Normal ventricles. But then there's some subtle things that we sometimes see, particularly empty sella. So make sure you look at the midline sagittal images. You're going to look for tonsillar descent, quote unquote Chiari. It's not a real Chiari. It's tonsillar descent, and it's usually fairly mild that some patients have. This one doesn't. And an empty sella. If you look, this is again the brain image, and it's best seen on a T2 weighted image because the vitreous is white, and it's just easier to detect the changes in contrast. But as you look at the back of the sclera, the back of the eyeball, you'll see flattening of the posterior sclera. As you look at the optic nerves within the orbit, you'll often see that optic nerve sheath complex is expanded and it's distorted. And this is an orbital image, but you can see it really well on here that the optic nerve is curved. You can see that the back of the sclera is flattened, and you can actually see the papilledema. So there's the optic nerve head, and it's sticking into the vitreous, and you can see the papilledema on the MR image. So does everybody need an MRV? At this day and age, probably everybody gets an MRV, and that's cool, that's all right. But definitely you should think about venous imaging in anybody who's atypical. A woman who's slim, any man who gets pseudotumors should certainly get an MRV. Children should get an MRV because often they have secondary cause of their pseudotumor syndrome. As women who are on birth control pill for sure should have an MRV. Because there's a potential that they could have venous sinus thrombosis. Patients who don't respond to treatment, you look a little harder for a secondary cause. I always send my CSF for cytology. I got burned once, so it changed my practice. That's how we all do it, right? There's evidence-based, and then there's I got burned. So after I got burned, now I send everything. I always send the initial CSF for cytology. Spinal fluid. Yes, you still need to do a spinal tap, right? Even if the MRI looks like the one I showed you, spinal tap is still required. You want to make sure the patient doesn't have something else, that they don't have some inflammatory condition or have cancer that's causing their symptoms. Remember that the pressure, of course, fluctuates. In all of us, like in our day-to-day life, there are times that our CSF pressure probably is 800 or 900 millimeters of CSF. And most of that time it doesn't bother us. But it does fluctuate. It goes high, it goes low. So what we do on spinal tap is just a snapshot in time. If it's not what you expect, you might want to repeat it. Occasionally, patients need intracranial pressure monitoring. If you're not really sure, maybe they're months down from their initial presentation. Maybe their papilledema is not so obvious anymore. So sometimes those patients need continuous monitoring. The patients may or may not get better after their spinal tap. We kind of like to hear that they get better, but they don't always get better. And sometimes they can get low pressure, headaches, post-LP headaches after their LP. So the response to lumbar puncture is not diagnostic. And patients who have migraine can have a spinal tap and get better after a lumbar puncture. So you can't really hang your hat on that. And you can't hang your hat on the number that you measure on the manometer. Associated conditions, there's like a gazillion of them in the literature. Most of them are case reports. The ones that are probably best substantiated are first, anything that obstructs venous drainage. So a venous sinus thrombosis, a jugular vein thrombosis. Exogenous agents, the best again substantiated are the cyclins, vitamin A, the retinoids, withdrawal from corticosteroids, human growth hormone, and there are other medications described with various degrees of evidence, if you will, supporting them. Endocrine disorders, the only two that have ever been shown in a case control study are obesity and a recent weight gain. Orthostatic edema or idiopathic edema is sometimes present. And I think polycystic ovarian syndrome, there's probably something to that. It hasn't really been looked at systematically. When we did the clinical trial, we asked patients if they had a history of polycystic ovarian syndrome, but we didn't test for it and we didn't examine for it, so it was just based on their report. And it was common, but I think it's probably more common than we think. Missed one. There's no definite association with hormonal contraception. The only exception to this being if the patient develops venous sinus thrombosis because they're on hormonal contraception. But if you think about it and just looking at the demographics around the world of women who are using hormonal contraception and how rare this condition is, it doesn't seem like there should be an association, and no one's ever really proved that there is one. There's also no definite association with pregnancy. So yes, this can happen during pregnancy. Case-controlled studies showed that it was no more common in pregnancy than in non-pregnant women, but it occasionally does happen in pregnancy. Having pseudotumor is also not a contraindication to becoming pregnant. So I get questions, people email me like from all over the world, I have this disease, can I have a child? Sure. So pitfalls and diagnosis, there are a few. One is patient has headaches and they have pseudopapilledema. And this is hard for us in neurology to figure out because when you're looking with a direct ophthalmoscope, you only get a two-dimensional view and it's not like the widest angle view on the face of the planet like in the pictures. So sometimes when the discs are a little bit tilted, it looks like papilledema, but it turns out it's not. And the other thing that can happen is optic nerve drusen. So this is a patient with tilted discs. And you can kind of get a better sense, I think, over here in the right eye that the disc is not up and down, right? It's got a little bit of a tilt to it. So there's that optic disc. And this optic disc is a little bit tilted as well. It's a little more prominent temporally in this case than nasally. Optic disc drusen are little calcifications that live in the anterior part of the optic nerve. Sometimes they're on the surface, like this one is, so you can see there's this bright white thing over there. And sometimes they're buried just under the surface, so they give the surface of the optic nerve kind of a lumpy, bumpy appearance. And again, when you look at the direct ophthalmoscope, it kind of looks like the patient has disc swelling. Sometimes these are really even hard to diagnose for the ophthalmologist. So we'll do ultrasound, we may do OCT, optical coherence tomography, sometimes even CT scan to determine that the patient has buried drusen. But this can all simulate pseudotumor. So what about pseudotumor without papilledema? How do you make the diagnosis of that? Well, there's two scenarios. If the patient has a 6 nerve palsy, but they don't have papilledema, and they meet all the other criteria, you're good to go. In my experience, and I would be interested to hear what my colleagues in the audience say, in my experience, people generally don't get double vision before they get papilledema. So I don't think that happens very often, but it's a possibility. If none of those are true, the patient's sitting in front of you and you're considering they may have this diagnosis, then we have some imaging criteria that need to be satisfied. So you need 3 out of the 4 empty sella, that flattening of the posterior sclera, distension of the subarachnoid perioptic space with or without tortuosity, or transverse venous sinus stenosis. Any 3 out of the 4 can make the diagnosis. So, I see these people all the time. It used to be, when I lived in central New York, that I would see acute pseudotumor patients. I loved that, okay? Now I see burnt out, maybe had pseudotumor patients. Dallas is just, there's a lot of stuff that goes on in Dallas with pseudotumor. What can I tell you? So I see patients now that come in that never met the diagnostic criteria. However, somebody has put in a shunt or fenestrated their optic nerves and put them on opioids for their chronic headaches. And this is the stuff that now I get to see in Dallas, Texas. It's not fun. It's not pretty. So it really isn't pretty. These people are a mess. They're a disaster. Their lives are ruined, right? Because nobody really made the diagnosis correctly. So, pseudotumor is one of those things we think about in patients who have new daily persistent headache, right? They develop a headache, it never goes away. Or chronic headache in an overweight woman. Yeah, you got to think about pseudotumor, absolutely. But if the patient doesn't meet the diagnostic criteria, they don't have pseudotumor. Even if you send them for a lumbar puncture and their opening pressure is 285, okay? They need to meet the diagnostic criteria. So I think that, and I'm not the only one that thinks this, but I think that IIH with papilledema is uncommon. I think it is overdiagnosed. My colleague, Kathleen DeGray, out in Utah, and her group, they looked at patients in their practice who had, this is a neuro-ophthalmology practice, who had pseudotumor with papilledema versus pseudotumor without papilledema. The people without papilledema were like 5% of their patients, which I think is actually kind of high. And compared to the patients who did have papilledema, it was longer for their diagnosis, so they were usually diagnosed 2 or 3 years into it. They tended to be less refractory, or less, responsive to typical treatment for pseudotumor. They didn't respond to acetazolamide, and they tended to have functional visual field loss. So, can you have it without papilledema? Yes, I think it's possible. But usually those people are not the acute presentation. Maybe they had mild papilledema at one point and it went away. But most of the time, I think this is being overdiagnosed primarily by headache specialists. And I'm one, so I can call names. Remember that, having a lumbar puncture is not a fun thing to do. A lot of patients are nervous. A lot of patients are in pain during their lumbar puncture. After, they miss a few times and the anxiety level starts going up, it makes your CSF pressure go up. So I would just say beware patients who have headaches and elevated spinal cord pressure, and that's all they have. I would not be making this diagnosis. Moving on to treatment, and this is kind of heresy. I don't think all patients need to be treated. And occasionally we see folks, particularly children, who go in for their routine eye exam and they have papilledema. And it's like, oh my God, now what do I do, right? So what I do with these patients is, first of all, I make sure they don't have a brain tumor. And if they don't have a brain tumor and they have an otherwise normal neurologic exam and they're asymptomatic, which these kids usually are, they don't have headaches, then I follow them. But you can't make an asymptomatic patient better. That's kind of one of my philosophies of life. So those people I tend to not treat, I follow them. The goal of treatment is to, what? Do I do TAPs? I don't always do TAPs. If they're otherwise healthy and they have normal MRI, and I'll usually get it with contrast, then I may just follow them. Again, these are usually kids. Sometimes I'll tap them. Sometimes they get tapped before they come to see me. But sometimes I will. Do you, if they're asymptomatic? Do you tap them?
Yes.
Well, you have kind of a bias of who you see too, right?
Yes.
Yeah, you're in the cancer hospital. Yeah, in that case, yes, I would tap them. Huh? No, they're like normal kids. And it goes away. I mean, there have been studies in the pediatric literature that if you follow them, that their papilledema just goes away. You don't really know why it happens. The goal is you want to preserve vision, okay? That's the number one goal. So the optimal treatment approach is having a team. Unless you're a neuro-ophthalmologist, you need a team. So neurologist and an ophthalmologist. This is from my beloved and deceased colleague, Dan Jacobson, who used to work at the Marshfield Clinic, which sort of was like the Mayo Clinic, I guess, but a smaller version in Marshfield, Wisconsin, where everybody kind of was in the same building and the patient would go to multiple people at the same day. But the ideal strategy was the patient would first see the ophthalmologist. The ophthalmologist does the exam, they do the visual fields. They document what the optic nerve looks like. Maybe in this day and age, they would also do optical coherence tomography. And then shortly thereafter, this miracle would have to occur, which is that the ophthalmologist would need to talk with the neurologist. Does that ever happen anymore? No. I mean, you can't even read the medical records. It's like, never mind, don't get me started. Anyway, you've been there, you know, right? So there has to be this like communication thing that goes on. So the ophthalmologist says, you know, this is what the vision is, this is what the field's like, they're better, they're worse, they're the same. And then the neurologist should be the captain of this ship, okay? It's us. We have to manage this disease. And the people, again, that I see that get in trouble, it's because they don't have somebody who's in charge, okay? Everybody needs a neurologist in charge of their pseudotumor. So the neurologist is going to take all that information, assess the headache control, decide what the patient needs with the ophthalmologist. You know, if the vision's going down the tube, maybe they need surgery. If their vision's not going down the tube, medical management. So what about medical management? A lot of different things we can do. So let's talk about them. Headaches. So a lot of folks have headaches. A lot of people with pseudotumor continue to have headaches even after their pseudotumor is treated and apparently under good control or maybe gone. They turn into headache patients. I don't know if they have central sensitization that occurs because they have elevated CSF pressure at some point, or maybe it's those 41% that had migraine, maybe they already had central sensitization, but they do turn into headache patients. So they certainly have headache patients during the they have headaches during the active phase of the disease. So again, headaches don't correlate with anything. Tapping these people repeatedly doesn't necessarily help their headaches. And medication overuse in practice is very common. So watch out for it. It's just like managing any other headache patient. I would recommend managing these headaches medically, not surgically. Please don't send this patient to be shunted for headaches, and I'll show you the data. The side effect on what you pick sort of depends on what you want to do and what you don't want to do, just like treating other headache conditions. So for symptomatic treatment, again, you want to make sure the patient doesn't overuse symptomatic treatments, but you could use triptans, you could use dihydroergotamine. Indomethacin and naproxen tend to not cause medication overuse. They're a little rough on the stomach, but they don't get people in trouble with their medication overuse. And indomethacin actually has a slight CSF pressure lowering quality to it. You can use antiemetics, you can use muscle relaxants. As far as preventative medications, I do like topiramate for this purpose. We didn't allow it in the clinical trial because of the carbonic anhydrase component, but I think topiramate works well, and I will often combine it with acetazolamide. Low-dose tricyclics we did allow in the clinical trial. Most commonly used was amitriptyline, and it didn't affect their ability to lose weight, much to probably my surprise and everybody else's. Other options that you can try as well. And for patients who have chronic headaches who fit the criteria of the phenotype for chronic migraine, onabotulinum toxin A is definitely worth trying. I tend to avoid headache preventatives that cause weight gain. So I don't use valproate, I don't use steroids, I generally don't use verapamil just because it can cause edema, and these patients often already have peripheral edema, and definitely I avoid opioids and butalbital. Acetazolamide, now we have evidence that it works, and I actually will show you the results of the trial, but the first choice is acetazolamide. The starting dose is usually about 500 milligrams twice a day, and you can increase it as tolerated to a maximum dose of 4 grams a day. Surprising number of our patients actually were able to tolerate 4 grams a day in the study. If the patient can't tolerate acetazolamide, furosemide is probably the second choice, or its cousin, I can never pronounce it, bumenidine. And the third choice is really kind of up to you. For patients who are truly allergic to sulfa and are allergic to loop and thiazide diuretics, which contain a sulfa moiety in them, the options include triamterene, spironolactone, and ethacrynic acid. You just have to really watch out when you combine the diuretics because patients can get in trouble with hypokalemia. So what did we find in the trial? Acetazolamide worked. So these are the data. And acetazolamide, this is the change in parametric mean deviation So patients with acetazolamide had 1.43 decibels of improvement compared to 0.71 with placebo, which was just squeaked by statistical significance. Is it clinically significant? Hard to say. That's not a huge difference. We see a lot of fluctuation in patients as they take visual field tests from visit to visit. But in patients who had the worst papilledema grades, they tended to have the best benefit. So certainly you would consider acetazolamide in patients who had high-grade papilledema. Papilledema grade also statistically significantly improved in patients who were randomized to acetazolamide, and every quality of life measure also improved, which I don't know how many of you use acetazolamide frequently, but my patients hate acetazolamide. They're that complain about it all the time. Makes me nauseated, nothing tastes good, my fingers are tingling, I can't stay awake, I'm stupid. And lo and behold, maybe they figured out they were getting active treatment, but their quality of life measures, both general and visual, all got better on acetazolamide compared to placebo. They lost more weight on acetazolamide compared to placebo, maybe because all that food tasted bad and they had to stop drinking soda, I don't know. But look down here, oops, headache, hit 6 disability, no different, okay? Patients did get better in the study, their headaches did get better, but there was no difference in acetazolamide versus placebo. Acetazolamide is not a good headache drug, right? More commonly, patients on acetazolamide had adverse events, the ones you would expect, right? And then there were a couple of serious adverse events. One person got kidney stones. A couple people had elevated liver function tests. I never really test those routinely before. It was only 2 patients, and it reversed when the drug was discontinued. But I guess it can happen with acetazolamide. We had one patient who was taking a diuretic and forgot to tell us about it. So she got pretty bad hypokalemia, needed to go to the hospital. One person had an allergic reaction. So on to other treatments, steroids. Yeah, they work. They decrease intracranial pressure, right? But we really don't recommend them unless the patient is like going blind in front of your eyes and you have to do something fast while the surgeon is sharpening the sword, right? So the problem with long-term steroids, they cause all those things that we're telling the patient not to do, right? Weight gain, and as the patient starts coming off the steroids, that increases the risk for developing or worsening their pre-existing pseudotumor. They can also cause high intraocular pressure. So you have an optic nerve that's already kind of struggling, and then you add intraocular hypertension to it, and that is a problem. Serial lumbar punctures. I do use them occasionally. Patients don't really like getting a spinal tap, but there is a subgroup of people that I think they're helpful for. Occasionally you'll see people that they generally do well, but every so often they have a flare-up. They come and they get a lumbar puncture. Okay. Pregnancy. I think it's very helpful for management during pregnancy. Why does it work? Why do we see these patients that they have their first spinal tap and then they get better? That doesn't make sense, right? We're making spinal fluid all the time. By the time they get home from the office, they have made up all that spinal fluid. Perhaps it has to do with their venous system and relief of that intracranial venous hypertension that makes it work. Surgical treatment we use for patients, again, who are losing vision, and there are a few options, so let's talk quickly about them. Shunting, you can have lumboperitoneal or ventriculoperitoneal shunting. Most people, I think, are doing more ventriculoperitoneal shunting these days. Lumboperitoneal shunting, it does work, but it has a very high failure rate. And it has the possibilities of causing an acquired Chiari malformation, so the patient can get what looks like low pressure headaches, and it can also cause visceral and radicular pain from that shunt catheter winding its way out of the spinal cord. This was a study that was done at Hopkins looking at 27 patients treated with a lumboperitoneal shunt, followed up for about 6 years, finding that more than half of them needed a revision, and the median time to the first revision was within a year, most commonly because of shunt failure. VP shunt is a little technically more difficult to do because the ventricles are normal in size, but with stereotactic placement, it's become much more doable. It avoids a lot of the complications like the Chiari and the radiculopathy, and you can use programmable valves. I happen to really love this study. It's a retrospective study that was done at Hopkins, kind of old data. They did, the second line kind of gives it all away, right? So all these patients had stereotactic shunts, 42 patients, 115 shunts. Okay, that's a problem. And they were shunted for headache, okay, pseudotumor headache. So you can see the numbers. A little less than half of them got away with one procedure, but most patients needed more than one procedure and sometimes more than 6 procedures. It worked initially, worked great, but as time went on, the headaches came back. So at a year, 20% of patients, their headaches got worse, and at 3 years, almost half of the patients had recurrent headaches. And the people that tended to do most poorly were people who had longer duration symptoms. So 2 years pre-op tended to not do well. The shunt failure rate at 24 months was 74% for various reasons, and lumboperitoneal shunts were more likely to fail than ventricular peritoneal shunts. When the patient had stereotactic placement, they got the shunt in, not an issue. So it's not, people need to go into shunting understanding that there's a really good likelihood that they're going to need another operation at some point. Optic nerve sheath fenestration, we don't really know how it works. So we're putting usually a window in that sheath around the optic nerve, around the subarachnoid space. So initially, yeah, there's some fluid that comes out. And the procedure is done under an operating microscope. So the oculoplastic surgeon will usually describe a gush of fluid that comes out. We have an experienced surgeon here that's given me this look. So you can join in at any time. So the gush of fluid, it looks like a gush because it's under a microscope. It's not a lot of fluid. It's like mLs of fluid, a couple, right? But they should see the fluid escaping from the optic nerve sheath. And either it works because it just lowers the pressure, because the window is cut in the optic nerve, but eventually the window's going to heal over, right? It's like every other thing in the body, it heals over. And so maybe it works because there are trabeculations that form between the sheath and the nerve that sort of prevent that head of fluid from coming down the optic nerve and causing more damage. So our data, again, retrospective, the papilledema usually gets better, sometimes in both eyes with a unilateral procedure. The visual field usually gets better, again, sometimes in both eyes. And the headache improves, although we don't do the procedure for headache. The complications are minor, although occasionally people do lose vision from the procedure, and it can fail just like shunts can fail. The advantage is basically there's no hardware. It's much simpler surgery, and there's no hardware to fail. And it may improve the vision in both eyes. What about venous sinus stenosis and stenting? So venous sinus stenosis is very common in pseudotumor. Some people say that if you look hard enough, that the prevalence of venous sinus stenosis in acute patients is close to 100%. The most typical thing that's described is the one in the middle, which is the extraluminal compression, causing the smooth-walled stenosis of the transverse sinuses. But you can also see intraluminal defects, which are probably caused by large arachnoid granulations or even discontinuities. In most cases that have been reported, it seems to be the result rather than the cause of the intracranial pressure. So the patient gets an MRV, it shows the stenosis, they get a procedure that lowers the pressure, they get rescanned, the stenosis goes away. So a lot of people are stenting. One of our neuroradiologists does stenting from time to time. There's certainly a rationale behind stenting because we know that venous hypertension is a problem, right? And maybe that is the problem. But it's really uncertain who should be stented. And most of the papers that have been published are retrospective. The criteria for being stented were not well defined. And it's not really clear how well this works or who this should be done on. The patient should have manometry. They should have their pressure gradient measured by manometry before considering stenting. And unfortunately, there have been some disastrous complications of stenting, including a death, including multiple cases of epidural hematoma, subdural hematoma, herniation, which fortunately reversed. But the patient has significant morbidity. So, pseudotumor is not a fatal disease. So I personally have not jumped on the bandwagon yet. I would probably consider it in somebody who was going blind and nothing else worked. Just a couple more special cases, pseudotumor in children. So this is different demographics in young children. Once puberty hits, it looks like the adults. But in younger kids, boys and girls are affected equally. There's often a secondary cause, either related to an ear infection and venous sinus thrombosis, or perhaps a medication. The opening pressure is a little higher in kids, but the treatment is basically the same in adults and in children. Pseudotumor in pregnancy managed a little bit differently, but not much. So acetazolamide can be used. We tend to wait until after the first trimester if we can. There's no great evidence that the acetazolamide is teratogenic. You can use repeated lumbar punctures. You could use steroids if you wanted to. Again, I don't advocate them, but it's a possibility. The patient could have surgery if they needed to. Then there's no increased risk of fetal loss or delivery complications in uncomplicated pseudotumor compared to anybody else. Again, venous sinus thrombosis is a different story. And then the ones that we all dread, right, are the fulminant pseudotumor cases. So these people come in, they already have vision loss right at the get-go. The first time they hit the emergency room or the eye doctor's office, which is where they usually go, they already have visual loss. And no matter what you do, they continue to have visual loss. And we do everything, right? We give them every drug in the book, and we do every surgery in the book. And sometimes, no matter what we do, the patients go blind. I always look for a secondary cause. Make sure they don't have venous sinus thrombosis. Sometimes it takes more than one imaging study to kind of figure that out. And there was a paper that came out of Israel several years ago saying that adolescent females may be more predisposed to this. And I will say that, again, in my experience, it tends to be younger women who get this. Either adolescents or early 20s tend to be the ones that just go down the tubes no matter what you do. Sometimes it's because they're missed initially. They go in and out of the emergency room. Nobody ever looks in their eyes. But this is just, the patient that we all really, really hate to see, and we try to prevent. So bad prognosis tends to be visual loss at presentation. Again, if the patient is lost acuity at presentation, you got to really jump on it. And we found that in the clinical trial as well. Uncontrolled systemic hypertension, profound anemia, systemic anemia is a problem. Patients who have pseudotumor associated with renal failure tend to not do very well. And venous sinus thrombosis, which again it's a secondary cause, but they are sometimes more difficult to treat. In the treatment trial, the ones that tended to not do well were the men. Remember, there were only 4 of them, but they didn't do very well. High-grade papilledema, and patients who had decreased visual acuity at baseline, particularly if they were randomized to placebo. So thank you again. I have a few minutes for questions, I think, but it's really a pleasure to be here. Come on, I know someone's got a question. We'll go to the microphone.
Thank you very much. Very informative talk. You mentioned both Goldman and Humphrey visual fields. What's the difference between them?
So Humphrey is an automated visual field machine. It's the one that you saw the printout from.
Okay.
And it measures static perimetry, so the lights are flashed in front of the patient. Goldman perimetry, you're kind of hard-pressed to find one anymore because most ophthalmologists use automated perimetry now. Only the dinosaur neuro-ophthalmologists usually have a Goldman perimeter in their office, but it's a manual perimeter. It's done with a perimetrist. It's not automated. And it does kinetic perimetry, so the targets move in from the side, and the patient presses a button when they see them move. And you can do kinetic and static testing, but it also does the whole visual field. So that's the advantage to Goldman perimetry, is you can actually go out and do the whole visual field rather than just a central part.
And why is it reported in decibels instead of lumens? Decibels are noise, lumens are...
I don't know. I didn't design it. I'm sorry.
All right. Thank you.
Foot candles. I would have made it foot candles, but... Okay, thank you. Wait, I thought Jade had a question. She gave up? You don't have a question?
Your experience with the transient visual obscurations and grade of papilledema.
I think they correlate with the grade of papilledema.
Me too,
Yeah.
But do you feel uncomfortable if it's grade 1 or 2 and they have transient visual obscurations?
Well, they don't really predict permanent visual loss. I used to really not think that much of them until I saw the quality of life data from the IIHTT, because they don't predict whether the patient's going to lose vision or not. But now that I guess I have a better understanding of how they affect people, then I am a little more aggressive than I used to be when they have them. But I do try to reassure people that just because you're losing your vision occasionally doesn't mean that you're going to go blind, because there really is no correlation with that.
About the correlation about the amount of edema and the papilledema and the size of the disc, like the cup-to-disc ratio, because this is important. If the size of the disc is big, that's most patients that we may see without papilledema.
So there's a question about the correlation between the degree of papilledema and the size of the disc?
Transient visual obscuration.
I'm not sure I understand the question.
So the size of the disc in correlation with the papilledema and the symptomatic transient visual obscuration. Is there any correlation?
I'm not aware of a correlation, of the absolute size of the disc? Like when it's not swollen?
The smaller disc, the smaller is the disc, is the more prone to be the edema is called like a vision loss and symptomatic, because there is no space. So maybe it might be something, but I don't know of a study, but it's a good idea.
Yeah, I haven't heard of that.
Like if somebody had a small disc.
Right.
And the disc edema was not so high that might still,
If they're more susceptible to damage because their disc is small to begin with? Maybe. I'm not aware of anything that's ever looked at that.
because this is what we found in our study when we did the study about the patient with pseudotumor survived without papilledema. It showed that the cup-to-disc ratio is the bigger the disc, they are less prone to develop
The bigger the disc or bigger the cup?
the cup-to-disc ratio.
Okay, that's not the question you asked. Okay, the cup to disc ratio may protect the patient in some respects.
How best to monitor the response to the treatment?
How do you monitor the response to the treatment?
Yes.
Mostly ophthalmologically, right? So you want to know what is happening with their visual field, and you also want to know what's happening with their headaches. But I don't routinely do lumbar punctures to see like where's your number today. I see patients sometimes who have had that done, and every 6 months they get a lumbar puncture just to find out what their number happens to be. I treat the patient, I don't treat the number.